So, did anybody else have a chance to review the minutes from the last meeting? And does anybody have any additions, amendments, or changes that they would like made?
I had 2 typos.
Okay, just submit those. Oh, glad to know that you know how to read a document to review. So can I have a motion to approve the minutes from October?
Motion to approve?
Second?
Second.
Any objections? Then let's approve the minutes and move on. Next item I have is organizational issues, which I think I'd like to keep brief. You guys need to figure out who your chairman is going to be in January. I can't do it anymore. You need to figure it out. That's a forewarned is forearmed, and in the January meeting, you'll be electing a new chairman. Hopefully, we may even have. I guess the process would be a little bit cumbersome to get them all. We have an empty spot. Do we have a nope?
Not that I know of. So it's been advertised,
So
but
it's
I
not-
haven't heard, as of a week ago, we didn't have anyone.
So
But
it's unlikely that we'll have a new face.
unlikely,
in the
but
seat.
not impossible. We
Not
have
impossible.
2 more Board of Commissioners meetings. And, we would do interview before one and proclaim the person at the next one. So
So it's
it's
possible.
possible, but if someone submits their
It's a
CV,
candidate identification problem.
that's right.
All right, so if you know anybody who might like to volunteer for your Township of Radnor Board of Health, I actually believe that in the coming weeks, months, and years, things may be difficult for public health, and I think that resistance at the ground level is critically important, so I would suggest that if you can identify likely candidates, it would be a good thing to fully staff out the board. And that's what I have for organizational issues. Any comments, criticisms, concerns? All right. Then I'm going to turn it over to Lisa for student intern program.
So I'm going to let Allison and Hannah speak briefly about basically what we discussed since last meeting was coming up with a plan, an action plan for basically the rest of the year until their presentations in May, and kind of discussing how their projects were going to manifest as far as research and implementation, et cetera. So I just wanted to give them a chance to speak briefly. And essentially the plan over the next month will be kind of doing literature reviews and basically gathering data so they're able to conduct their interviews and obtain more information directly from people with good knowledge. But I'll let them speak briefly.
So I kind of narrowed down my topic to how physical exercise and mental health, such as and also breathing techniques, can help reduce anxiety in teenagers. And over the next few weeks, I was going to look over some literature and kind of try to expand the topics and get into some of the specifics of it, as well as talking to Miss Roseland at Radnor High School. And I was kind of hoping through talking to her, I can try to find out what specifically concerns Radnor High School students and how I can incorporate that into the project.
I was hoping to first do research on nutrition, especially in school lunches for teenagers, and hoping to meet with people in charge of the school lunches and seeing how much of the standards, of course they meet the federal standards, but how much of, the health, the benefits they meet. And I was hoping to research Radnor lunches specifically to see if there were enough nutrition for the teenagers at Radnor High School.
So I think they have a good start. Essentially, kind of gathering information so they know like what areas they want to specifically concentrate on, and then, you know, pursuing those areas. I mean, I think an interesting thing will be federal standards may be changing, so kind of looking at current federal standards and for school lunches. We do have some contacts within, Alice was saying, Ms. Rosland, she is in charge of Mental Health Week or it was last year at Radnor High School. We just determined that May is Mental Health Month, or reviewed that May is Mental Health Month, so be an excellent month for her to do her presentation for us. And then her plan also was to maybe implement some flyers with relaxation techniques or ideas and hang them around the high school. So that kind of works with, so I think both projects right now are it's kind of good timing.
I think stress relaxation is needed all around. Thank you. Anything else you ladies would like to add at this point? So Lisa has agreed, since there has been no other, what's the word, mentor to step up to mentor for both of you. I will be happy to help out behind Lisa to give assistance that you might need in research methodologies, and so maybe we should have a talk between now and the next meeting if possible. Okay? Does that sound good? Mm-hmm. Great. Any other comments from anybody? Okay, so with that, the next item that I put on the agenda is Dr. Leacher, our newest member. If I may, Lee, may I? Okay, Lee and I were talking after our September meeting when she joined and discussing that although there's been a dramatic endemicization of the COVID-19 acute infection, we now have an epidemic of long COVID syndromes, and she volunteered to give a talk on post-COVID syndromes. So without further ado, and with Ian coming out to set up the slides on the big screens, I'm going to turn the microphone over to Dr. Acker.
Thank you. Should I stand up there to advance the slides, or
Yeah, if
you want me to
come
come
down.
There's your answer.
Okay. Okay, so as Dr. Simon said, I'll be presenting on long COVID or post-COVID condition. And one of the first things to review actually is the terminology being used. Many terms have been present in the literature and used casually and sometimes clinically since 2020. Can you hear me okay? Okay, thank you. And those include post-acute COVID-19, chronic COVID-19, post-acute sequelae of COVID-19 or PASC, post-COVID-19 syndrome, long-haul COVID, and simply long COVID. And all of these terms have been used to describe a collection of symptoms that span physical, cognitive, and mental health domains and multiple organ systems, which we'll get into further in a moment. In 2021, the WHO conducted a multidisciplinary expert consensus process and adopted the term post-COVID-19 condition. And they define this as a condition that occurs in individuals with a history of probable or confirmed COVID infection, usually 3 months from the onset of COVID-19, and with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. Of note, in July of this year, an article in the New England Journal of Medicine described the process of the National Academies of Sciences, Engineering, and Medicine in defining the term long COVID, which had been patient coined, and it recommended revisiting the terminology and meanings in 3 years. So that shows the ongoing work to classify, name, and define some of what we're talking about. So symptoms that this condition encompasses are varied and many. They include those affecting, again, multiple organ systems and again span physical, mental health, and cognitive domains. This is a short list of a very large group of symptoms that have been reported in post-COVID condition. Certainly, there has been much talk about the partial or total loss of sense of smell and altered sense of taste. The most common symptom of long COVID is fatigue, but every organ system has been implicated, again, as you can see. One study reported persistence of at least one symptom in 87.4% of patients who recovered from COVID and showed a predominance of fatigue and dyspnea being shortness of breath. And of note, the fatigue is often described as profound exhaustion that does not improve with rest. Brain fog is also important to talk about. It's not a medical nor scientific term, and it's generally used by patients to describe sluggish, fuzzy thinking or thinking that is not sharp. So regardless of how we classify these symptoms or the syndrome overall, which again will continue to crystallize as time goes on, it's clear from the breadth and the prevalence of these symptoms that there is quite a large burden on patients following exposure to COVID. With regard to the mechanism of the development of post-COVID condition, research is ongoing, but current theories of the mechanism of the development of post-COVID condition are some of these that are listed here. An autoimmune response, so the immune system produces antibodies that target a person's own organs and tissues. Remaining virus, this suggests that after the immune system eliminates the coronavirus, some remnants survive in one or more organs and continue to stimulate an immune response, and that immune response may damage tissues and result in chronic inflammation and lead to these symptoms. Reactivation of latent viruses. So as we know, there are viruses that may remain in the body in a dormant state, such as Epstein-Barr. And there's evidence that in people with post-COVID condition, these inactive viruses reactivate and may lead to the symptoms described. Factors relating to gut microbiome. So here the viral infection upsets the gut's ecosystem and the virus may be able to survive in the gut and spread. Endothelial dysfunction, which was talked a lot about during the initial phases of COVID, where endothelial cells, which line the innermost layer of blood vessel and gatekeep vascular health, are impacted because the COVID infection alters the balance of endothelial protective and endothelial damaging molecules, and that leads to dysfunction. Organ damage, the body's immune response to the COVID infection damages organs and tissues and leads to symptoms. And then vagus nerve damage. So the virus damages communication in the brainstem or the vagus nerve, which controls autonomic functions in the body. Of course, there's thought that the symptoms are due to a combination of any of these or other possible mechanisms. So this is an interesting graphic from the Lancet Respiratory Medicine, and it shows the potential trajectories for survivors of acute COVID-19. You can see the differential weights of the arrows illustrate potential proportions of patients who develop post-COVID condition following severity of initial COVID disease. So again, further research is needed to better characterize these trajectories, but as you can see, there's a greater proportion of patients who experienced severe disease and were hospitalized or had an ICU admission, who then experienced post-COVID condition, and a lower proportion of those with mild disease who did not. But interestingly, a patient does not have to have symptoms in the initial COVID infection in order to present with post-COVID condition. So certainly this has implications when we talk about protecting the population, since rates of severe illness and therefore attitudes have changed since the initial outbreak period. So mental health considerations are of particular importance to me as a psychiatrist, but they also represent interesting considerations with regard to mechanism. Research has shown that as many as 90% of individuals hospitalized with COVID and 25% of non-hospitalized adults experience at least one brain or mind-related symptom. Again, includes fatigue, headache, sleep disturbances, depression, anxiety, 6 months after the illness in these cases. But some of the main presenting symptoms of post-COVID condition here, again, anxiety, depression, poor memory and concentration, and even PTSD symptoms. And when we look at how these symptoms come to be, again, there are the direct viral effects, wherein neuroinvasion, neuroinflammation, immune dysregulation, and chronic inflammation can contribute directly, as seen in mood disorders. There's been research showing low levels of serotonin and reduced glucose metabolism in the brain in patients experiencing post-COVID condition. But there are also psychosocial factors, wherein social isolation due to ongoing health issues can lead to further symptoms, particularly of anxiety and depression. Health anxiety also factors in with regard to concern for reinfection or development of long-term symptoms. And then post-COVID condition symptoms on the whole have the significant ability to impact a person's daily life and functioning, including limiting return to work or stress with normal routines. Those interruptions in functioning then lend to greater mental health challenges. Another point is the development of PTSD triggered by history of severe illness or hospitalization. Sleep is also impacted in several ways. Sleep disturbances themselves are a symptom of post-COVID condition, but also with sleep disturbances as a function of change in daily routine, social isolation, and again, the anxiety, the depression, and the PTSD. And then, of course, poor sleep in turn exacerbates these and other symptoms. Several million people are estimated to be affected by persistent symptoms of COVID, with conservative figures indicating at least 65 million people worldwide. Data suggests that 22 to 38% of people with COVID will have at least one symptom 12 weeks after initial onset, and 12 to 17% will have 3 or more symptoms. With 80.5 million confirmed COVID cases in the United States, this implies at least 9.6 million people with 3 or more symptoms. Of course, numbers of confirmed cases have increased since that publication, so numbers are even potentially higher. Another study estimated 8.4 million adults with 3 or more symptoms. Not only are there clear health risks associated with post-COVID condition, but the majority of patients generally report a worsening quality of life. So the burden is great, and estimates of cost are quite high. David Cutler at Harvard delineated 3 economic costs of post-COVID condition: cost of lost quality of life, cost of lost earnings, and cost of higher spending on medical care. And calculating for these 3 costs, estimates for the total cost of post-COVID condition is $3.7 trillion. Further, cost of research focused on post-COVID condition is an important but costly area of burden. So current research is focused on clarifying the biological and neurological mechanism of the development of post-COVID condition and the epidemiology and risk factors for developing it. It also looks at pharmacologic and non-pharmacologic treatments of it. Current treatment approaches being considered include symptom management, so things like therapy for fatigue and sleep issues, cognitive rehab, pulmonary rehab for cough and dyspnea, cognitive behavioral therapy for psychological symptoms and distress relating to chronic illness, medications for depression, anxiety, and insomnia, anti-inflammatory agents to reduce inflammation and cytokine storms, post-viral fatigue treatments, which include targeted therapies for mitochondrial functioning. So again, importantly, people can develop symptoms of post-COVID condition even if they did not experience symptoms during the acute infection. This could be where symptoms were mild or where the infection was truly asymptomatic. And this is another of many reasons that both vaccination and testing continue to be very important despite changes in the severity of outcomes over time. And while there's a range of symptoms and presentations of post-COVID condition, it can result in chronic conditions that can be severe. Organ damage and severe inflammation as part of post-COVID condition can lend to a higher mortality and generally to greater health risks. And as always, vaccination is important not only to protect ourselves and immediate circles, but for the population effect as breakthrough infections occur as vaccination rates decline. Vaccination remains our key strategy in preventing acute COVID infection and long-term COVID outcomes. And testing is, of course, important in order to identify cases early and efficiently. And then with regard to management of post-COVID condition, it often requires a multidisciplinary approach with comprehensive teams involving different physician specialists, mental health professionals, rehab specialists, and others for effective management. So finally, I want to touch on strategies to help with some of the symptoms I've mentioned. When we talk about brain fog, for instance, the recommendation is to pursue activities that we know to be generally helpful for cognition and memory. And those include aerobic exercise, even if it's starting small for just a few minutes a day, healthy diet, particularly generally a Mediterranean diet, rich in vegetables and whole grains, socializing, focusing on strategies to promote good sleep, including going to bed at the same time every night, setting a pre-bedtime routine that allows your brain to prepare for sleep, listening to music, and practicing mindfulness. Any questions?
Did you come across any data when you were reviewing if vaccination tends to decrease the occurrence of long COVID
It's,
Or we're just not sure yet?
it's a very good question. They're just not sure yet. It seems to, and I think indirectly, when it brings down rates of the severe disease, which seem to have a higher proportion of lending to long COVID, but it is not entirely clear. And there is a ton of research ongoing.
So not to step on your punchlines, but I think it was in JAMA last week, there was an article published from a very well sorted out French population, so within a healthcare system that actually keeps demographic information, and they provided pretty clear evidence that vaccination was associated with a lower risk of developing COVID in a well-matched population, of developing a post-COVID syndrome. And the other one that I saw just recently was a similar study showing that if you use Paxlovid within the first 5 days of the initial infection, there was also a lower risk. So I think that confirmatory evidence is always desirable, but I think that it appears to be emerging that treating yourself well to prevent and treating yourself well if you have will both diminish the probability. Other questions? So you mentioned something that I actually found pretty interesting, and it was the mitochondrial function. And there was also recently published out of University of Minnesota a study that showed people on metformin actually have a lower incidence of developing long COVID. Now, diabetes was my area of expertise. We started using metformin in this country early 90s because we had problems with that class of drug with the drug that was approved on this market. In Europe, they've been using it since really essentially 1980. So there's a 45-year history of metformin as a safe and effective drug in the management of diabetes and in the most recent couple of decades pre-diabetes. But I go through this tirade because we still do not know the exact target of action of metformin. We don't know how it works, although most people working in that area believe that it works at the mitochondria. And this Minnesota article showing that people on metformin had a lower probability kind of, to me, overlaps with the notion that there may be a mitochondrial function that is somehow affected by the mechanisms you point out, inflammatory, infectious, neuroendocrine, whatever. And I say that because my most disturbing symptom of my long COVID syndrome is a post-exertional malaise. Feels like, if you have an old phone, the battery goes down really fast. Feels like the battery just goes off the cliff. And I just, in ruminating on that, just wonder if the power plant of the cell, the mitochondria, might be a central
Implicated, absolutely.
focus.
Yeah.
Just speculating. So thank you, Lee. That was really excellent and very much appreciated. And from my point of view, we are probably moving into a phase of pandemic where the post-COVID syndromes are going to occupy more space than the acute COVID syndromes. Okay. So with that, you're going to have to listen to me for a couple more minutes because my agenda item, the community infectious diseases, I think we're entering a phase where we really have to rigorously adhere to the science and do everything we can to avoid the politics, but are going to be progressively less likely to be able to avoid the politics. So I'd like to start with a story on history, maybe history of politics before the community infectious disease update. And it's a story about a president and January 6th. It is not a story about our newly re-elected president or January 6th of 2021. It is a story about a man who was not yet president, who on January 6th of 1777 signed a decree. His name was George Washington, famous liberal. who on January 6th of 1777 signed a declaration that all members of the Continental Army would be vaccinated, and vaccinia is cowpox, not smallpox, but vaccinia, vaccinated, actually specifically refers to smallpox inoculation. All the other inocula are not really truly vaccinations, although we call them vaccinations. It was completely apparent by the end of 1776, the winter in Valley Forge, not far from where we are right now, that casualties in the Continental Army were 2/3 infectious diseases and the rest casualties of war, and that the most significant of those casualties from infectious diseases was from smallpox. And to quote General Washington, necessity not only authorizes but seems to require the measure, for should the disorder infect the army in a natural way and rage with its usual virulence, we have more to dread from it than from our enemies. And he took the brave step of inoculating them. The mechanism of inoculation then was to make a small slit in the skin and then take a hair or fine thread imbued with live virus, and to run that thread through the small slit to produce a small dermal reaction. This was brilliant early immunology to cause people to develop an immune reaction through skin-based cells and antibodies, rather than the deadly form, which was acquired through inhalation. And it worked, because now we have a republic if we can hold it. And it was a brave move on the part of the men who became the first two-term president. And I say that because in the interim, inoculation has become a standard and consistent part of being inducted into the armed forces in the United States. I last looked, I think there are 12 or 13 inoculations that you need to take to be in active duty. And every time that it has been looked at, inoculation programs as a public health measure, I'm not talking about individual decisions, but as a public health measure, can be shown to save thousands, tens of thousands, hundreds of thousands, or even millions of lives. And a recent analysis, again from, I believe this was from the French literature, showed that calculated approximately 11 million lives saved by COVID inoculations. So that's enough on the general and philosophical, and I'm sure this will not be the last that we talk about inoculations. With regard to the infectious disease season that we are entering, and I would also note that we had, by both anecdote and account, one of the most stringent fall allergy seasons, with runny noses and coughs that might have been hard to distinguish in memory, in probably no small part on account of the drought in which we are in the midst. We're now in the historical cold and flu season. I first would point out that there was an epidemic of the so-called walking pneumonia, which seems to be decreasing. Walking pneumonia meaning it's not a pneumonia that hospitalizes most people. It's usually from Mycoplasma pneumoniae, but other non-tuberculous mycoplasma susceptible to macrolide antibiotics. But the emergency rooms in the middle of October were filled with people with pulmonic complaints. But there, from a COVID point of view, there was a large peak, we talked about it last time, which seems to have waned just in time for holiday season and the opportunity to generate another peak. Remembering that COVID is, if you look at the peaks that have occurred over the 4 years and of the pandemic, it is not a seasonal disease. The peaks have occurred in virtually every season, in both of the northern and southern hemispheres, making it, to me, a little bit difficult to combine inoculating for influenza with inoculating for COVID. And I choose not to do that. I also choose because from my internist point of view, even though severe reactions to one and the other are both rare, if you had the unfortunate outcome of having a severe reaction and you got both shots at the same time, you would be stuck historically with determining which one you had the severe reaction to. At any rate, from a public health point of view, people are pushing simultaneous, and from a public health point of view, if you can get more people inoculated, it's probably more important than separating out the very rare severe reactions. There are three other things. COVID is not highly active now by wastewater, although there was an uptick in the Midwest. But all the other places, wastewater activity is low, hospitalizations have decreased to a low baseline, and deaths have decreased to a low but present baseline, and there are still people dying by the hundreds. Influenza and RSV have not yet reared their ugly heads. They are both ticking up, but ticking up at an order of magnitude below what you would expect when you finally get the peak that we are almost certain to see. So you still have the opportunity to get flu vaccine and be protected prior to, and if you choose to get the RSV vaccine, that as well. But there is an issue, and it is pertussis. And I'm going to go back and again defend the notions of inoculation and vaccination. I saw online today the comment, if you walk through any of the historical cemeteries, I've been to historical cemeteries on 3 continents, but if you walk through the historical cemeteries in this country, there are lots and lots of babies that are in the historical cemeteries before 1950. And when you look, the number of babies that are buried in these cemeteries decreases exponentially after 1950 when pertussis vaccination came into play. In fact, before 1950, 10,000 children a year died from pertussis in the 1940s. And after, when penetration levels were high, a busy pertussis year for total cases was 10,000, with severe disease being about 10% and mortality being much lower than that. Pertussis receded dramatically from historic levels during pandemic, which is attributed to, but not proven to be a cause of, social isolation, hand washing, masking, and virus avoidance precautions. Over the last couple of years, it has ticked up, and this year it has returned to pre-COVID levels, about 10,000 a year, but there's significant concern that may not be the end of it, because there has already been a drop-off in percentage vaccinations. We know that school entry preclusions, which you're entitled to on the basis of religion or personal health. You can get a preclusion to the school requirements for vaccination. They went up from 1.8% in 2020. They're now well over 3.5%. Measles vaccination fell below the 95% mark that people feel is required for herd immunity and to prevent outbreaks. And there are measles outbreaks in 37 of the states in this country. There were less than 10 measles cases every year since 2000, up until 2 years ago when it went up to 8 or 9. Last year it was under 100, and this year it's well over 270. 40% of the cases of measles are hospitalized, and the mortality rate, I lost my notes, I don't have offhand, is not insignificant. And smallpox and polio have also made re-entries into the world after having been declared obliterated. So that's my community infectious diseases. That's a jolly story, but that's my follow-up. Any comments? Kiki, are you on the line? If you're muted, you may need to unmute. Kiki didn't join us because she had a viral syndrome that she didn't want to share. But she had asked today, one of the folks from Savage Sisters had asked for the opportunity to get onto our agenda in order to have another community event. I told her that we already had an agenda and that was late, but we could put it on the new business but it doesn't seem that that's going to happen. But you can expect for our agenda next meeting to hear from Savage Sisters for an attempt to re-establish that connection and give them the opportunity to make presentations to the community. So with that, I'm going to turn it over to Maggie for an update from the Board of Commissioners under new business.
Thank you. I don't have much for you in the public health realm. It is comprehensive plan season and it is budget season. So the township should have a new comprehensive plan up and getting ready to go out there in January. The plan is being presented at Board of Commissioners meetings in thirds. So we had the first section, you can look at them on YouTube if you're interested. The first section, which was on sustainability and some things that had not previously been in our comprehensive plan. So it was really interesting. And then Monday, we will have the second section. But it's all getting out there. I think even the third section is now out there for you to read on the website. So Radnor2035.com, and you can find all that information, or it's on the township website.
I actually read it.
Oh, good.
Quite a document.
It's quite a document.
Thank you to the Board of Commissioners. Quite an effort. I think it took me a little longer to read Moby Dick, but I'm not sure.
I've been doing it in thirds because I'm part of the steering committee, and so that makes it a little bit easier. But even getting through it in thirds, it takes a while.
It's an impressive document.
It's an impressive document. Well,
Thank you.
our thanks to our consultants that are helping us with this and have actually helped us apply for a grant, which we received, to really study downtown Wayne for some potential changes there. So that'll be good. We'll get some traffic numbers and flows and that sort of thing.
And I was thrilled to see that light and sound pollution made it to the
Yep.
agenda.
And then otherwise, we're pretty much doing budgets. We did get a grant to put solar panels on the roof, so that was fine. That was in the works anyway, but we got a grant for part of that, which is good. EV chargers are going out in the lot. I don't have a whole lot else for you. All I do is read papers and look at numbers. So.
Well, thank you, and thank you for your efforts, and thank you for your representation here. It's invaluable. I'm actually going to tell a story that I've told anecdotally, probably to everybody, and you're sick of hearing, but when it comes to sound pollution, the last time that I was in Paris was for my 70th birthday a couple of years ago, and we stayed in a hotel in a very busy district, right between the 6th and the 7th, right off a very busy boulevard, the Boulevard Saint-Germain, maybe 100 yards off, and we were able to sleep at night with our windows open because in Paris, they have gone to electric buses. And they are so quiet that the street noise has diminished dramatically. And I say that because you don't necessarily think about noise pollution, but it is really a thing. And I also say it that in the event that you're a burn baby burn and don't believe in electric, there are values to electric above and beyond the not having a tailpipe pumping poisonous gases into the environment. And noise pollution is one of those things. Anybody else have comments? So
Even the propane buses are better than, are much quieter and put out almost no exhaust. So there are several ways to, I was talking to Villanova today about getting their shuttle buses all switched over to either electric or propane.
I think one step at a time, but these are changes I think are pretty close to inevitable.
Yeah, and when you're doing something new,
There's always
just put it in there, put in the solar panels, put in the electric buses or the propane or whatever your bus of choice is. I think people like the propane because they go a little further on a single tank/charge, but it's obviously not as good as electric, so.
Think that we just had a guest arrive from Savage Sisters.
How's it going? Sorry I'm late. Terrible traffic.
Yeah, hopefully most of them were driving electric cars. No, I'm sorry. So we have a little bit of time left, and I had felt that you might not be coming and said we would put you on for next month, but you're here. We have time on our agenda, so please take the podium. Please introduce yourself and let us know what we can do.
Hey team. Hey team, thanks for having me back. It's been a little while, but not too long. I'm Adam Al-Assad, the Director of Operations at Savage Sisters Recovery. Savage Sisters is a nonprofit operating in Philadelphia and Delaware County, offering recovery housing, harm reduction outreach, and overdose prevention and reversal education sessions for the public with a focus on schools and first responders. Today, I wanted to come back and talk to you guys about collaborating on a listening session. Savage Sisters has been doing listening sessions for about the past year throughout Delaware County specifically, as we wanted to really just inform the residents and the businesses of Delaware County about the resources and services that we at Savage Sisters offer, as well as other parallel organizations and entities throughout the county offer as well in relation to recovery, first responders services for mental health, as well as recovery, and outreach programs in general. So we've hosted them in Chester, we've hosted them in Havertown, we've hosted them in Upper Darby, and we've done them in collaborations with the townships there, as well as with other organizations that operate in those townships. So again, the goal of these listening sessions is really just to inform the public of what we offer, as well as other organizations, and in doing so, open them up to the opportunity to ask questions about those, provide their input into resources and services they might like to see added to those options, and in doing all of that, break down some of the stigma in relation to those resources and services, because we all know throughout the nation, but especially in areas outside of the city, there is a lot of use behind closed doors. People don't feel comfortable talking about substance use. They don't feel comfortable talking about financial insecurity, and breaking that stigma down, because that is what it is a big part of these listening sessions. So my clear ask is to ask you, the Radnor Board of Health, to be one of the 3 hosts on the listening session in Radnor Township. Hopefully we can use this building. We've done it before for an actual overdose prevention and reversal education session, which we did with you guys, as well as the Radnor Police. And the third partner in that event would be the Radnor Police. We've spoken with Chief Flanagan. He's on board. He actually recommended that we get with you guys and make this a 3-entity listening session.
Board of Health, Police, and?
Savage Sisters.
Okay. So what do you need from us specifically?
To put your stamp on being a host for it, and then assist in marketing it, as well as be there on the day of to add any input that you might have as well. So list other mental health services that you might know of that are available, other recovery services, other financial services. Invite any other organizations or entities that you might think would be appropriate in being here. During those listening sessions, there is a panel of speakers. So there can be anywhere from 3 to 6 speakers on that panel. We would have one from our staff sit on the panel. We would have Chief Flanagan sit on the panel. There would also be a chief from another police department that has sat on the panel consistently and has provided some really valuable insight as well, with his lived experience in relation to recovery. I don't want to lock down those 3 to 6 listening session, those 3 panelists right now. I think further communication would be necessary for that. Firstly, I just wanted to get your stamp of approval on being on that.
Right, so we don't need to set an agenda now.
No, certainly not.
So I think, yeah.
I-
Could have been.
She's on. She said her audio's cutting in and out, and she doesn't have video, but she is here. Yeah,
Okay.
yeah.
So is there any comment from members of the board?
So thank you for coming and offering that to us as an opportunity. I think it's definitely valuable. Just curious, you frame it as a listening session. It sounds like it's a panel discussion and series of presenters to talk about what's available and to raise awareness. Is that?
Exactly. Ask questions, ask for feedback. There is a Q&A section as well. But yes,
So
exactly.
people that come will hear a series of presentations, and then they'll be able to ask the esteemed members, whoever is going to be presenting. They'll be able to, the members of the community, will be able to ask their questions about disorders, diseases, treatment.
Almost exactly. I would just change the language of a series of presentations. It's more of a conversation. There isn't long, sections that are focused on one person's entity or mission or anything like that. There's a lot of back and forth, a lot of dialogue. But yes, other than that, that is exactly what it would be.
And one other question, what kind of turnout have the other sessions seen?
We've had anywhere from 5 to 30 people show up, with the average probably being about 10 to 15. And the ones that have closer to 30 are typically because one entity brings a group from a community that they serve, for example. Everybody from one board will come. But we like to have a variety of folks from the community, from a lot of different groups. We don't want one person to bring 30 people, and then it just be a conversation between one group and our panel.
Other comments? Maggie?
Well, I think it actually maybe should be something that's done annually, on a schedule. And I don't know if you want to do it, pick a drug awareness month, or, where's Alex when we need him? He knew what every month was. But that it is a good idea. And I don't know if you need to do the panel discussion each time, because you did that lovely, more of a physical hands-on workshop when the police were here. That was great. But I think it's incredibly important. And yeah, you'll get some different people coming, but I think if it's well advertised, and it could be advertised as a Board of Health lecture series, which we have, and it would be recorded separately and get out there on both YouTube and on the Township website. I don't know, what do you think?
So it sounds to me like we have general agreement that it's a good idea, and that at this point, it's a logistical issue, and I was under the impression that Kiki had assumed the mantle from Alex for being the liaison and responsible for handling those logistical issues, and as far as I'm concerned, that's how we proceed. You and Kiki figure it out,
Okay.
make it happen.
Sounds good enough to me. She was already texting me some contacts and links to move forward, so I think we'll be able to get that done pretty effectively.
I would ask Kiki if you're out there and can hear me, or if not, we can get in touch, but to keep Ian in the loop, because he does do the recording and getting things out there for folks, and he would need to know that he, needs to be here or stay late or whatever, if we did it after a meeting, whatever. So once we get down to the specifics, just loop Ian Myers in.
So what is it Captain Kirk used to say? Make it so, number one?
Absolute.
So
And- I'm sorry, excuse me, what's the timing for that? Could you say that again?
They take anywhere from an hour and a half to 2 hours.
The date.
We have not locked that in at all. The sooner, the better. That's where we're at. We've been doing them all over the place, and now that we have the format, it doesn't take us any time to set up. So once once I speak with Kiki, we'll look for the next date that's available here in this facility and go from there.
I agree with the sooner the better, but I would just amend it I would recommend giving us enough time to brainstorm how we can get as many people here as possible.
Makes sense.
Between all of us, we probably have connection to a lot of different groups, and it would be nice to try to pull a diverse group of listeners.
I would also suggest that if you wait till January.
Yes,
don't
that's
try and go before January.
before the holiday,
As soon
exactly.
as possible after the holidays.
Yep.
That's the way I would phrase it. I think you'll do better.
So I'll aim for mid to late January then.
And that would give us opportunity to brainstorm how to get as many people here as possible.
Perfect.
Great.
I have a comment. Just Alex provided me with a contact list of people that have come to past events, so I can give that to Kiki as well.
Thank you so much. All right. I appreciate y'all's time, and thank you for your patience. Yeah. Go take my Monday night. Thank you all. Thank you all.
So with that, I see no other, I don't know whether that was old business, new business, or public participation, but I see no other old business, new business, or public participation. So I would like to ask our esteemed board for a motion to adjourn.
Motion to adjourn?
I'll second.
So moved and seconded. Meeting is adjourned.